So a common question that patients might ask would be, when should you see a specialist for shoulder arthritis? Most patients, they don't necessarily know that they've got shoulder arthritis. They just know that their shoulder hurts them. And so one of the reasons to see a specialist would be to help define and diagnose what is the problem. There's lots of different types of shoulder pain and different etiologies and causes of that. And so you want to kind of determine, is this shoulder arthritis? Is this a rotator cuff tear, or is there something else going on with the shoulder, sprain, strain, whatever? So typically you've got pain in the shoulder, you've got stiffness in the joint, you've got a loss in your range of motion. Mechanical symptoms include grinding, clicking, or cracking, which is what we call crepitation or crepitus. You can see the pictures at the bottom of the slide. The far left shoulder picture shows a normal, healthy joint. You can see that white cartilage both on the ball and the socket. Cartilage's job is to really cover the bone and protect the bone. Cartilage, there's no pain when a normal, healthy joint works because there's no nerves in cartilage. Cartilage can rub on cartilage from the day you're born to the day you die. If you have a good, healthy joint, you'll never have pain in that joint. Arthritis is when you lose the cartilage that covers the bone. There's lots of nerves in bone. If you break a bone, it hurts because there's nerves in the bone. When bone starts to rub on bone, the nerves in the bone on one side of the joint are rubbing on the nerves in the bone on the other side of the joint, and those nerves don't like that, so they send a message to the brain that you've got pain, and that's basically where the pain of arthritis comes from. You think about just boiling everything down. Joint replacements work by covering up the bone again, and we resurface the joint with metal and plastic. There's no nerves in metal, there's no nerves in plastic. Metal and plastic can rub on one another. And as long as the bones are happy again under the implants, the nerves in the bones are no longer sending a message of pain to the brain. And that's how joint replacement works for all different types of arthritic joints to solve the pain problem. You can do the next slide. So what treatments are available for shoulder arthritis specifically? Once you've seen a specialist and you have the diagnosis that it is shoulder arthritis, then we typically start with conservative treatment. Just as all forms of arthritis, typically that includes an anti-inflammatory and or acetaminophen. So acetaminophen, Tylenol, most people would take that as extra strength Tylenol, which is 500 milligrams in a tablet. We typically recommend 2 tablets each time you take it for a total of 1,000 milligrams. And typically we take that about every 8 hours. That's typically a very safe amount of acetaminophen, and it's safe for the liver, and it works. A lot of people that take acetaminophen, they really don't take enough, and they don't take it as often as they should to get relief. Anti-inflammatory medicines is the other common medication that's used. Those can be over-the-counter or prescription. Over-the-counter is typically Advil, Aleve, Motrin, Naproxen, those over-the-counter anti-inflammatories. I like a prescription anti-inflammatory called meloxicam, otherwise known as Mobic. The nice thing about it, it's one of the safest anti-inflammatories we have, and you only take it 1 time a day. So it's very easy to take, and it lasts all day. And it's a little bit less likely to irritate your stomach or irritate your kidney or heart, etc. You know, some people use topical creams. Anti-inflammatory creams exist, Voltaren gel, all the typical off-the-shelf creams that you can get, Bengay, Icy Hot, Flexol, BioFreeze, Blue Emu. You've seen commercials on TV, and some people use those types of creams, and they can help. The more aggressive conservative treatments would include injections into the joint. The most common and typically most studied would be a corticosteroid injection. Just like you can do in the knee and the hip, you can do it in the shoulder. And we can hit that joint pretty well just by palpation in the office and going through the portals that we typically use surgically. And that's been used for many, many, many years. You know, some people use hyaluronic acid. It's really not FDA approved. I'm not a fan of that because it's not FDA approved. And as a rule, hyaluronic acid has really not been shown in most joints to make a big difference. PRP has been discussed when it was talked about with the hip replacement. Again, it's kind of early infancy of knowing what the indications for PRP would be and how that really works. But there's not a lot of good literature that shows that it really helps arthritis of the shoulder, but they're continuing to study that. So that may be something that could increase in frequency in the future if it's shown to have better benefit. So exercise is important. One of the things that's not really been talked about is you get endorphins when you exercise. Endorphins are feel-good hormones that your body produces only when you exercise. And so getting regular exercise, your body produces endorphins, and it helps you to compensate for the pain of the arthritis. Physical therapy is a good idea. It doesn't have to be too many visits, but a doctor of physical therapy can give you a basic program that you can work on your range of motion so you don't get too stiff, and work on some basic strengthening so you maintain your strength and function. And again, just the endorphins that are released by exercising that joint actually helps to combat the pain at that joint. Alternative therapies would include things like massage therapy. You could consider acupuncture, bee sting therapy. There's all kinds of alternative therapies out there that you could try. Supportive garments. Some people would wear kind of a neoprene sleeve that gives a little compression. There's Tommy Copper things, questionable benefit, but they make those for almost every joint. Sling could be used intermittently. Braces are pretty rarely used on the shoulder. Heat and cold therapy, there's got a lot of benefits to that. A little bit of mild, moist heat and some mild cold therapy, and alternating those especially can give some pain relief. So that brings us to surgical treatment. The two main types of surgery that could be considered for someone with shoulder arthritis would include arthroscopy and finally shoulder replacement. Arthroscopy, one of the main indications for that would be a subtype of shoulder arthritis. The subtype would include arthritis at the AC joint, the acromioclavicular joint. That's where the clavicle comes and meets the acromion. And that small joint, you can resect that joint, and that can give tremendous pain relief if your arthritis is basically isolated to the acromioclavicular joint. Some of the other reasons you might think about arthroscopy could include if you've got loose bodies in the joint, you could go and arthroscopically remove the loose bodies. If you've got a torn labrum, you could go in and trim that soft tissue that surrounds the socket to help minimize the mechanical symptoms of a labral tear. And oftentimes the biceps tendon can also start to shred and tear, and doing a biceps tenodesis arthroscopically is another thing that could be done to minimize pain in early stages of shoulder arthritis. When the shoulder gets arthritic enough, typically we resort to shoulder replacement, which is very similar to what you've already heard with hip replacement and knee replacement. Basically, we remove some bone, and when we remove that bone, we replace the bone that we removed with a metal and plastic joint. And that solves the pain problem because metal and plastic don't have nerves, and the bones are happy again under the implant. And actually, the function is quite good. There's two main types of shoulder replacement. One would be an anatomic shoulder replacement, which maintains your anatomy the way God made you. And the other is a reverse shoulder replacement. And we'll get into that very shortly. So next slide would be shoulder arthroscopy. We talked about this. It's typically for earlier stages of arthritis that are not that severe. We can direct this treatment at a loose body in the joint, a little piece of bone that's drifting around. If there's some torn tissue around the socket, the labrum, if the biceps is torn, if you've got AC joint arthritis isolated, we can resect that joint. It's called a distal clavicle resection, otherwise known as a Mumford procedure. And those procedures can be very, very helpful. There's lots of people that have earlier stages of arthritis where the arthritis is really not that severe, but yet they've got a lot of pain from these other diagnoses that you can kind of cure and resolve pretty well with arthroscopic techniques. So the next slide would go into shoulder replacement. The procedure is typically called a total shoulder replacement. You know, some of the earliest shoulder replacements were called hemiarthroplasties. That's when we did not replace the socket. They had inferior outcomes, and so that's pretty rarely used today. Typically, almost all surgeons would elect to do a total shoulder replacement, which means you replace both the ball and the socket. If you look at the right-hand side, the top picture actually shows a picture of arthritis of the shoulder. You can see that there's not much space on the radiograph between the ball and the socket. That kind of shows that the bones are rubbing together, and that's where the pain of arthritis comes in, because the bones are rubbing and the nerves in the bone are irritated with that process of heat and friction. The second picture down, the middle picture you see, is a picture of an anatomic shoulder replacement. You can see that basically we resurface the joint, and we don't really alter the anatomy. You still have the ball where the ball's supposed to be, and you still have the socket where the socket's supposed to be. On the socket part, you can't see much there because that implant is primarily plastic. there's just a little radiographic marker in the middle of that socket that kind of shows where we've placed that implant. The bottom picture is an example of a reverse shoulder replacement, and you can kind of see why we call it a reverse shoulder replacement, because we put the ball on the socket and we put the socket where the ball was. So we reversed that anatomy. You can also see that we kind of lengthen that arm. If you look at the distance from up at the clavicle to the top of the shoulder, it's longer on the bottom picture than it is in the middle picture. And that helps to kind of stretch the deltoid, and it facilitates the deltoid being the prime mover of the shoulder after reverse shoulder replacement. One of the main reasons to do a reverse shoulder replacement would be if you've suffered a major rotator cuff tear that could not be fixed. And that would still allow you to solve the pain problem of the arthritis by doing a joint replacement, but also improve function by restoring the ability to raise your arm up overhead by using your deltoid. So that's basically how joints work and the major types of joint replacement. We can move on to the next slide. What can you expect after surgery? So now, thankfully, shoulder replacement just in 2024 has become an outpatient surgery. We now can do that at an ambulatory surgery center, which is where most orthopedic surgeries are now done. Most orthopedic surgeons would prefer to operate at an ambulatory surgery center because typically it's better for the patient in a variety of reasons. I do almost all of my surgeries outpatient now. That includes hip replacement, knee replacement, shoulder replacement, rotator cuff repairs, fracture work. It's amazing what we can do on an outpatient basis at a facility that is geared towards just doing orthopedic surgery. So what you can expect after surgery, arthroscopy, it's outpatient. You get it done, you go home the same day. It's typically done through about 4 small wounds, one in the back of the shoulder, one in the front of the shoulder, and typically 1 or 2 on the side of the shoulder. That's pretty straightforward. You take your dressing off after a day or 2. You've got those small little wounds. You see us back in the office a week and a half to 2 weeks after surgery, and you start your process of recovery, which includes some physical therapy. There's obviously some restrictions based on exactly what we did and what your diagnosis was, whether that was an arthroscopic procedure or whether that was a shoulder replacement, but you'll have some instructions. Typically, we instruct you before the surgery. I like to make sure that people go to physical therapy before the shoulder surgery so that they have a better understanding of what they need to do right after the shoulder surgery, and also to set up an early physical therapy appointment after the shoulder surgery. So shoulder replacement, very similar. Now it's something that we can do outpatient. People get it done, they go home the same day. And we use regional blocks when we do shoulder work. So it's very effective. Anesthesiologists will actually numb some of the nerves around the shoulder before you have your surgery, and that block still stays in effect, very similar to a dentist who numbs your mouth before he pulls a tooth. And that block works for many, many hours after the surgery, so you get home before that block starts to wear off. And so shoulder surgery used to be one of the more painful surgeries, but now with revolutionary anesthesia techniques and the regional blocks, it's really improved pain control. And so shoulder surgery is much less painful than what it used to be just a number of years ago. So follow-up appointments we schedule with the surgeon. Typically, that's a week and a half to 2 weeks out for your first postoperative check. Oftentimes, that would include getting some x-rays after the shoulder surgery to check on the positioning of the implant if you had a joint replacement, or potentially the resection of bone if you had an arthroscopic procedure. There's a slow, steady progress of recovery. I like to tell patients as soon as you wake up from your shoulder surgery, if it was a joint replacement, you can say, hey, I no longer have shoulder arthritis, and you do not have the arthritic pain that you had before the shoulder surgery. You wake up, there's a different type of pain. You have some pain because we just did shoulder replacement or an arthroscopic procedure, but the main reason for your pain before the surgery is gone. And the surgical pain, that's a pain that's it backs off pretty quickly, and before you know it, you're much happier and much more functional with a joint replacement or an arthroscopic procedure about the shoulder. The next slide is my introductory slide. I've been out in practice since 1998. I went to the University of Dayton for my undergrad. I then went to the Ohio State University for my medical school training. I went up to Henry Ford Hospital in Detroit, Michigan, a very tertiary trauma center and very, very busy surgical hospital, and had great training there. And I'm born and raised in Mount Vernon, Ohio, which is not very far from Newark, Granville area where I practice. And I've enjoyed my 26 years of practice so far and look forward to additional time and seeing patients. So come see me if you have any shoulder problems. Thank you very much.